Welcome everybody to the Neurology Video Journal Club. Today we'll be talking about a paper looking at the prospective long-term follow-up of focused ultrasound unilateral subthalamotomy in Parkinson's disease that's published by Raul Martinez, Jose Obeso, and their group in Madrid. I'm Binit Shah, a Parkinson's disease and movement disorders neurologist at the University of Virginia, an associate professor and director of our Parkinson's and Movement Disorders Center. And I'd like to welcome my co-discussant, Professor Elena Moro.
Hello, everybody. My name is Elena Moro. I'm a professor of neurology at the Grenoble Alps University. If you don't know exactly where is Grenoble, it's very close to the Alps and to Lyon in France. I'm a movement disorder specialist, and I'm the director of the movement disorder centers at the University Hospital of Grenoble.
Well, and very modest of you, Elena, to not talk about how beautiful Grenoble is, even though you're
all welcome.
I haven't been able to join you despite your invitations. So as I mentioned, we're here to discuss this paper related to long-term outcomes of unilateral focused ultrasound subthalamotomy in Parkinson's disease. And maybe before we get into the details of the paper itself, we can go over some background. So perhaps, Elena, if you'd like to briefly sort of give an overview of the current evidence-based sort of paradigm for invasive treatments in PD.
Indeed, thank you, Binit, because we are talking here about invasive treatment for Parkinson's disease. And I think who is in the field, they know that recently the European Academy of Neurology and the European session of the Movement Disorder Society, they published guidelines for invasive treatment in advanced Parkinson's disease. So what we know now from the current available evidence based on randomized clinical trials and using the GRADE methodology, we have a very strong effectiveness in improving motor symptoms using pumps, the apomorphine pump, which is subcutaneously infusion of apomorphine, the levodopa, carbidopa intestinal gel infusion, and we have the brain stimulation from the subthalamic nucleus and the pallidus internus. These interventions are very effective to treat advanced Parkinson's disease motor symptoms, and subthalamic deep brain stimulation is also recommended. It can be recommended when we have patients at the beginning of motor fluctuations. We have also lesions like the unilateral radiofrequency pallidotomy that can be recommended when the brain stimulation is not available in the country. Considering MRI-guided focal ultrasound, what the available evidence is saying, well, actually is not saying too much, because the randomized clinical trials are still lacking because they are small, or they are even smaller concerning the other symptoms besides tremor in Parkinson's disease. But beneath, we know that high intensity focal ultrasound has been used a lot in the United States, a lot in Europe for treating movement disorder. So I think we really have to get much more information about this treatment. And you know very well this treatment in your university. So can you tell us what does it mean to have this treatment? Can you tell us a little more?
Yeah, thanks, Elena. And I think you know, we've had a lot of experience at the University of Virginia, particularly with essential tremor and with tremor dominant Parkinson's disease, looking at focused ultrasound lesioning of the VIM nucleus of the thalamus. But what we don't have as much experience with is some of the other targets that treat other, especially cardinal motor features in PD. So the slide I'm showing here is the setup for the MRI guided focused ultrasound. And on the left pane is a patient and this is an essential tremor patient getting a tremor treatment to the VIM nucleus, but the setup is identical in that the patient's head is shaved, and what that does is help reduce the trapping of heat between hair and the scalp. For some of us, that's not much of a concern, but for many patients it is. So the head is shaved, and then there is a bladder that's filled with body temperature water, and at the ends of the bladder are ultrasonic transducers. So 1,024 ultrasonic transducers that sort of create a hemicircumferential pattern of focused ultrasound energy. And in the second pane, you can see, at least in a two-dimensional representation of that, where those beams of ultrasonic energy converge is our designated target. Again, in this case, the thalamus. And the third pane shows the post-lesional T1 MRI. So we see that there's a lesion that looks very similar to lesions that are produced, for example, by radiofrequency lesioning. And we see that there is this thermal lesion or thermoablative lesion that's produced by the ultrasound. But part of this treatment is clinically based in addition to coordinate based. And so when the subjects or when the patients are in the MRI scanner and having the ultrasonic sonications, there's stepwise increase in the amount of energy that's delivered, and that can be monitored by MR thermography. So this is an MR thermograph showing that the target is heating up compared to the ambient temperature of the brain and, of course, the fluid-filled bladder outside of the scalp. And so with increasing sonication energy, there should be increasing temperature at the target. We start to see changes in physiologic effects around 50 degrees C, and we can see some tremor reduction. We can see potentially changes in other features of Parkinson's in the case of this study that are often temporary, and adverse effects that may be temporary, and that can allow for adjustment of the target, with the final sonication being typically 60 degrees C for about 10 seconds.
So, Binit, if I can ask you a question. So, are patients aware, fully aware that we are talking about lesion, right? Is it less invasive compared to the classical pallidotomy or thalamotomy, subthalamotomy, but is a lesion? So, do they understand that maybe if there is any side effect, it will be forever? Or, what is your feeling about?
That's a great question, Elena. And I think that whenever we see a new treatment that's available, and this may have been the case with DBS, and when the group at Grenoble developed this now almost 40 years ago, there's excitement, and that excitement we want to make sure is appropriate. At the same time, there can be hope that we want to make sure we harness, but at the same time are not telling patients things that aren't correct. And so many patients will come thinking, well, there's no incision involved in this procedure, and therefore there are no risks of side effects. And a lot of our time is spent in telling patients, no, this is a surgical procedure like any other, including DBS. We have to align what the symptoms are of the disease with what the procedure can offer, first of all. And then secondly, understand that there are potential adverse effects and that the treatment is a static treatment. So, unlike DBS, which has a dynamic component of the pumps that we can adjust, the focused ultrasound is a static treatment. And so even if the benefit is potentially limited, we can't get additional benefit based on changing parameters after the fact.
Perfect. I think we are ready to go through this paper. What do you think?
Right.
Can we
I think so.
discuss a little more?
Yes, I think so. So this is a prospective, and on the slide here, you can see it's a prospective open label follow-up extension of previous work that this group has done using unilateral focused ultrasound subthalamotomy. And now they're looking at results at 3 years. So their primary outcome co-measures are, one, the change in the motor subscore, the MDS-UPDRS Part 3 of the treated side, so the contralateral side, and difference from baseline score to 36 months. And this score range is 0 to 44 when considering the sort of unilateral treated side. And then their second primary outcome measure is safety. And they determine safety by grading adverse events into 3 categories: mild, moderate, and severe. And the descriptions are there: mild meaning not affecting any activities, moderate affecting routine activities, and severe basically causing inability to perform activities of daily living. And then there's a list of secondary outcome measures that were quite rich in what the group presented, including MDS UPDRS Part 3 of the treated side from baseline to 36 months in the on medication state. And I don't think I mentioned, but the primary outcome measure is in the off medication state, which is typical when we were assessing surgical treatments in PD. Also looking at some of the axial, or rather some of the subscales within that treated side, as well as some other aspects of Part 3, including axial features, the overall total UPDRS Part 3 in the off and on medication state, other aspects of the MDS UPDRS Parts 2 and 4, as well as the PDQ-39, the Parkinson's Disease Quality of Life Scale, PDQ-39, and a satisfaction scale that was assessing the patient satisfaction or subject satisfaction with the treatment after the fact. And then I'll just pull in, so they analyzed 32 subjects for this 3-year follow-up out of the 45 that were initially part of their unilateral focused ultrasound subthalamotomy group. And what they found was a 10.1 point reduction from baseline to 36 months on the treated side off medication score. In terms of safety results, they had 11 mild adverse effects that were persistent at 3 years, 2 that were moderate, and none that were severe. And of those, some adverse events that they reported included levodopa-induced dyskinesia of the treated side, the contralateral side, that was present in 27%. Clumsiness and weakness of the treated side, that was present in 1 subject, dysarthria in 1 subject, and subjectively reduced verbal fluency in 1, as well as weight gain in 2 subjects. And then highlighting some of the secondary outcome measures that I know that you'll sort of put into context for us, Elena. The treated side UPDRS Part 3 on medication reduced 7.8 points from baseline to 3 years. The total UPDRS off medication reduced 8.8 points. Dyskinesias slightly worsened, sort of straddled 0, slightly worsened by 0.2 points. Motor fluctuations didn't change at all, and that should be a 0 in front of the 0.9 to minus 0.9 to 0.9. Levodopa equivalents increased slightly, so medication burden was flat to have a slight increase at 36 months. Quality of life showed improvement that was not statistically significant, and satisfaction was quite high from these 32 subjects at 3 years for having had the procedure.
Excellent. I think that, Binit, you summarize very nicely the methodology and the main results. And I really think that is an interesting paper, right? Because in the first paper they published in the New England, the same group in 2020, they compared 25 subjects who had the surgery compared to 13 with the sham surgery. And at that point, the differences in points in the treated side was 10. So basically, we have the same improvement, which persists for 3 years in the same side. So I think the first important message of this is that, again, this treatment maintains over the year the same benefit. And this is, I think, is very important for this initial area of the brain that we are targeting with this procedure. And the other, as you pointed out, is that the, let's say, persistent adverse events were mild. We are talking about lesion. This is the reason why you stress that, patients, they have to be aware that this is a reason. But overall, these side effects were few and mild for the patients who actually thought that this treatment was very satisfactory, and you pointed this. And we have to remind that also the brain stimulation can give us some side effects. Of course, usually if you turn off the stimulation, they disappear, but both surgery, they can have some side effects, and we have to keep in mind that. And then the secondary outcomes. I think what is striking here is that levodopa was not, the medication were not reduced. As you said, actually we can see an increase over the years. And again, this is a bit striking because the patient, they say we are satisfied, but they don't modify any treatment. And we know that sometimes the patient, they want to reduce absolutely the medication because they don't like it, right? And also motor fluctuations, they did not change. They didn't improve, and they were stable over the years. So what I would retain from these secondary outcomes is that this intervention is likely not indicated to patients who have relevant motor fluctuations because they will not improve, or patients who have medication-related side effect because this will not be improved by this kind of surgery. So what do you think about this first analysis, Binit? Do you have anything to add to this first?
And I think, I agree with those points you made, Elena. The first is the safety aspect, which I think was very reassuring to say, okay, we have concern about subthalamotomy, and there's clearly thought that lesions in the subthalamus that are targeted in patients with PD may not behave in the same way as, say, a vascular insult to an otherwise healthy individual that could lead to hemibellism or chorea, or things that we could be concerned about. So this is reassuring. It does go to what we'll talk about later, which is, all of these subjects were treated at a center that really has expertise in doing this. But as far as some of the secondary outcome measures, value and oftentimes the long-term benefit of STN treatment, whether that's DBS or a lesioning procedure, is often related to the ability to reduce particularly levodopa-based medication to help reduce some degree of dyskinesia that may be present, potentially motor fluctuations as well. And this is something that I think can come up as well with unilateral DBS and the STN, and there's quite a lot of literature there, but I don't know in your experience if patients that we know will get bilateral STN, if they get one side first, it becomes very challenging to manage their syndrome until the second side is done.
Yeah, indeed. And you stress this. This is in the context that it looks that this surgery can be suggested to people who have very asymmetric Parkinsonism, right? So, which is usually at the beginning, because their patients are both bordered by, by the two sides of the body. So they should have a strong asymmetry. So you make this lesion, they don't fluctuate. So very mild fluctuation. So they don't border if there is no improvement on the mild fluctuations. And I wonder if we do a unilateral STN DBS in these patients, how they will be in the future. So should we be able to reduce the medication in the future, so to reduce the dyskinesia that eventually they will develop maybe in a little more over the years? We know that this is happening. I think it will be interesting, right, to compare maybe, as has been done for unilateral thalamotomy and contralateral VIM DBS, if no, it can be a new way to treat a particular group of people, which is maybe a limitation of the study that just, or a good thing of the study, that just this specific population of patients has been operated.
Yeah, and that is an important thing to note, that these were patients that were fairly mild in their Parkinson's as far as early in the overall PD process. The duration of disease was less than 10 years on average, and as such, they tend to be fairly asymmetrical and unilaterally predominant in terms of symptoms.
Yeah, and also, Binit, there is no control group. It's an open study, so there is no the limitation. The authors, of course, they stress it, but we have to keep in mind, right, that these are limitations of the study, and results were dishomogeneous. You know, there was not all the patients that had a very good outcome. That even if overall the patient they went well, there are some of them they did not do very well, right? So the results are heterogeneous. The other thing that I want to discuss with you, what do you think, Binit, why these patients were so happy? They're very happy, satisfied, but the activity of daily living, they don't improve. I was asking myself why. So do you have any answer to that?
Well,
what do you think?
I think it's twofold. I mean, I think we see that there's clear benefit in the motor syndrome, and you know, part of what we consider with our treatments, especially if we apply them earlier, is to try to shift the needle. You know, shift the needle to delay potentially need for medication, dyskinesia, and at a certain point, if we go 10 years, 15 years out, our numbers will get smaller in this cohort, but also the impact of any surgical treatment might become less as axial features or balance and gait issues or cognitive issues become paramount. So how we measure overall quality of life at that point versus baseline may not be such a favorable comparison, but the satisfaction will still be there that, hey, I had this procedure and the next day my Parkinson's was doing better. I had less tremor, which, you know, we can say, well, tremor is something we have very good treatments for, but for patients, it's a very unsettling symptom. And it's a very overt feature of Parkinson's that patients like to have treated. And I think this treatment clearly has shown it does a good job of doing that, and safely.
Yeah, I totally agree. But surely the mechanism of action of a lesion like the focal ultrasound lesion is different from the mechanism of action of the brain stimulation, which allows, as we discussed, to reduce the medication, the modulation of the brain is surely different. But this study is not addressing the pathophysiological mechanism, but I think it's very intriguing to discuss these differences, and probably we will need much more studies in this direction in the future. So, Binit, which kind of implication we can have from this study? What do you think? What is your vision about the implication? What would you? Does it change your life?
You know, so yeah, and I think the question that hopefully most of the viewers have is, okay, well, where will this slot in if this becomes available? You know, we have focused ultrasound pallidotomy available in the United States now. How does this slot in based on where things are? Well, first, the simplest is some patients will say, I will never have any hardware implanted in my body. I refuse to have deep brain stimulation. And we have to look then at each treatment in isolation and say, does this have value? Is this safe? And I think, you know, the paper from this group has gone a long way in showing that not only is it safe at the long term, we see benefit that's durable. The two other main aspects I'd say is, one is access. So, you know, Dr. Abeso has published quite a bit about doing radiofrequency subthalamotomy in parts of the world where there's not access to deep brain stimulation, that there's not access for patients to come for regular programming. So people who live in areas of the world or even in countries that there's less regular access to care,
yes,
and less resources of care, this could be a possibility. And then the second really goes back to what we're talking about, is people who have very early Parkinson's. And I shouldn't say mild, I should say early, in that the unilateral features can be quite problematic. but where they're not having medication-related complications to a great degree. And if we can shift that needle and say, okay, well, here's somebody who's working, here's somebody who may have a young family, we can provide a treatment that then can delay the need to consider returning to another advanced treatment, or even to really increase medications. And I will mention one other thing, Elena, and essential tremor and PD are very different diseases. But we did have a paper from our group that showed that we were able to salvage a focused ultrasound thalamotomy lesion whose sort of duration of benefit was not so great by implanting a VIM DBS lead into the same nucleus. So I think one thing to also keep in mind is a unilateral focused ultrasound subthalamotomy doesn't necessarily exclude patients from them going on to have DBS, either in different targets, certainly, possibly even in the same target. I don't know what your thoughts are about that.
Yeah, no, Binit, I agree. So we might have some disparities in assessing this treatment because it's expensive, by the way. You need a very experienced multidisciplinary team to guarantee the results, that the patients are well studied before having this treatment. You need to collect data to know if there is other side effects that maybe we don't see today. And also, I think, as you said, that there are some special patients who will benefit much more than the others. So these are, I think, the most important thing that they have to guide us in the next few years where we have to go with the treatment. But I'm very happy that we have it, because for the patient that it can benefit is really a good thing. So I think that we are enthusiasts for the enthusiasm for this paper is still there. But we think that we need much more data, much more research to give us much more information in this area.
Yeah, and I agree, especially the need to have a comprehensive evaluation, like we do in deep brain stimulation. Multidisciplinary team, movement disorders neurologists, functional neurosurgeons, neuropsychologists, nurses, having off and on medication testing, neuropsychological testing, and really developing a plan for treatment is important, and identifies the patients who will get the best benefit and perhaps in the safest manner possible. That's really important. And so the access to this treatment might increase, but we certainly don't want people finding themselves in a arena of having focused ultrasound lesioning just by seeing a television ad or a magazine.
Yes. No, we are professional.
Yes.
But let's think, Binit, maybe even with people who will listen to us in the next days, in the next months, that maybe we should think, to design a new trial, to put together a big database, data coming from subthalamotomy, the focal ultrasound. I think it should be nice to collect all this data and to advance the field.
I think definitely, the more ubiquitous this treatment becomes, the more we should have much of this longitudinal data. But like you said, well-designed prospective evaluation is really what we need to have, and this goes a long way to us getting that, but plenty more for us to learn about these types of treatments.
Very good. So Binit, I think we said the most important things about this paper. We hope that people who are listening to us, they've been happy with our comments and our insights of this paper. So we thank everybody for listening to actually it's probably one of the first video round journal on movement disorders, right, Binit? So we are happy to start the interest of movement disorders. So we thank everybody. Binit, I don't know if you want to thank somebody.
Yeah, I thank you, Elena, and thank the AAN, and thank everyone for watching.